Welcome back, everyone. So our next presenters will present on ethical challenges in neuropalliative care. Marianne Sofronas is a nurse, ethicist, and anthropologist. She worked clinically for over a decade as a nurse clinician in the Neuro ICU and as a clinical ethicist for the MUHC. Marianne completed a PhD in nursing at McGill in 2023 and is currently completing a postdoctoral fellowship with the Palliative Care and Nursing Ethics Hub at the University of Ottawa. She is also a faculty lecturer at the Ingram School of Nursing at McGill. Justine Gauthier graduated with a Bachelor of Nursing Science in 2009 and a master's degree in nursing with a specialization in nursing education in 2014 from University of Montreal. She gained additional training by doing a graduate certificate in Palliative and End-of-Life Care at University of Sherbrooke in 2020. Justine has been working at the Montreal Neurological Hospital since 2008, starting on the neurosurgical unit as a staff nurse. She then worked in the Neuro-Oncology ambulatory clinic as nurse pivot between 2013 and 2017. She has been the nurse clinician working in the Susan Cameron School Neuro-Palliative Care and Pain Program since its creation in 2017. Alongside her hospital work, Justine is a part-time course lecturer to nursing master students at the McGill Ingram School of Nursing since 2023. Together, they will address ethical dilemmas in neuropalliative care. Let's welcome Justine and Marianne. Thank you.
Your mic, I have my mic. Great. Hi, everybody. Can you hear us well? It's nice to be here. It's nice to see so many of you here too. I'm glad that you were able to join in person. How many people do we have online actually?
Right now,
Nice, a good turnout. We're going to start by doing a land acknowledgement. I'm sure you're familiar with those. We wanted to acknowledge that McGill University is located on unceded territory of the Kanien'kehá:ka or Mohawk peoples. So we recognize and respect them as traditional custodians of the lands and the waters on which we meet today. And just to add a little context as well, and this is something I've learned from one of my colleagues at McGill, land acknowledgements are nice to do, but it's also nice to contextualize them to our own realities and to reflect a little bit on what it means for us to be standing here today. And so I did spend a bit of time thinking about my own relationship with Indigenous peoples. And, you know, I come from a long line of settlers here in Canada, from France back in the 1600s. And so I'm part of this as well. And I have to be mindful of that in my practice in nursing, but also I think as a human being. And so how I work on reconciliation myself is to try to keep myself educated as much as possible. And when I do have patients that are Indigenous, I always try to understand their reality as best as I can and to make sure that I provide care that is coherent and that is good in their eyes and not necessarily from my own perspective. Did you want to say something? No? Okay. We don't have any conflicts of interest to declare, unfortunately. Okay. So you guys just ate. You might be sleepy. Hopefully we'll be able to get you to participate today with us. We're going to review key concepts in nursing ethics, and we're very lucky to have Marianne, who's an ethicist, with us here today. We'll talk about the unique challenges in neuropalliative care, and then we'll go through case reviews. We have 6 cases to work on today with you, so we'll be happy if you jump in and join the discussion on those cases. That's really the objective of our talk today. Okay, great.
So let's start by looking at what are we talking about when we talk about ethical practice, and where do we go for guidance when we're thinking about how to practice ethically? And so there's a number of different places we can go. And the first is, so quite often in ethics, when I get called for consultations, clinicians will often say, I don't really know how to approach this. Just tell me what the law says. Tell me what is legal. Tell me what is illegal. And that's what I want to do, is to really not break the law when I'm practicing. And I think that's a great objective. But I want to point out that the law is actually just the basement layer. And so just because you are following the law, which is very important, and I don't recommend that you not, but just because you're following the law, it doesn't mean that you're actually acting ethically, right? And sometimes you could follow the law and actually act very unethically. So the law is the basement layer. And so what laws guide our practice? Well, there's a whole bunch of legislation, and I'll talk specifically about Canada and in Quebec. And so we've got articles from the Canadian Constitution, and we've got the Charter of Rights and Freedoms. We've got common law in Canada and civil law, the Civil Code in Quebec. And there's articles in all of these frameworks that guide our practice. And so beyond law, and because we are a regulated profession, and Natalie touched on that this morning, but because we are a regulated profession, we also have our own codes of ethics. And so there's the CNA Code of Ethics for sort of outside of Quebec, and then we have the OIAQ Code of Ethics here, very similar in spirit, but maybe some different language for different issues. But I mean, overall, there's a lot of similarities between the two. And so beyond that, and our codes of ethics are based on concepts from moral philosophy. We're not going to talk about moral philosophy today, only just to say that it's a branch of philosophy which is concerned about this question of the good. What is this notion of the good, and how do we determine what is the good in each situation? What is right versus wrong? What is just versus unjust? What is good versus bad? And that can vary from one situation to another. And so moral philosophy was in a lot of ways considered to be kind of a finished discipline. Like everything had been sorted out from the ancients all the way to the 20th century. There wasn't a ton going on in moral philosophy until the 1970s, where we saw the advent of bioethics. And this kind of exploded moral philosophy. And a lot of the questions that were being asked in the 1970s in bioethics were because of a lot of technological advances that we had seen in healthcare. And so in the 1920s, we saw the iron lung being developed, so the beginning of positive pressure ventilation. In the 1950s, we had the development of ventilators and vasopressors, which transformed acute care and allowed a lot of patients who were otherwise going to die to survive longer, right? In the 1960s, we saw the development of CPR. And so this is very, very new technologies. And so for a long time, when these technologies and interventions were developed, because there had been nothing before, there was no question that you were going to offer everything to every patient in every situation, right? And so it was only in the 1970s when there started being questions about, should we be offering everything to everyone? Are there certain things that might be preferable in certain situations? Are there situations where we shouldn't offer certain things? And how do we go about withdrawing treatments when we've begun them? So these were big ethical questions. And so bioethics is a field developed to address a lot of these questions. From there, we will see the development of nursing ethics also, because bioethics is a great literature. But when you read it, you almost get the impression that the only thing that is happening in healthcare is an encounter between a physician and a patient, and no one else really exists. And so the language that they use is very much built on medical practice. And so beyond bioethics, there was in the decades that followed the development of a literature on nursing ethics that really recognized the unique ethical dilemmas that we encounter as nurses and how we can go about addressing them. So in practice, how do we go about making decisions, and what guidelines or what frameworks do we use to help us? I don't want to bore you with like a review of different frameworks, but maybe we're going to look at two main ideas. And so when we have an ethical dilemma and when we want to arrive at a solution, the most important part is the deliberation. And so it's the weighing of the different values and principles. It's thinking about what the patient wants, what is medically advisable, what is the best option under these circumstances, and so on and so forth. And one of the main frameworks that we use in bioethics is this framework of principlism. How many people have heard of principlism? Yeah, okay. Principlism developed in the 1970s, and what they wanted us to be careful of is to not make ethical decisions or make any kind of analysis of ethical problems based on our opinions. We all have opinions, and that's super important. We all have values, things that are important to us, but we shouldn't make decisions based on our own opinions or our values of what we think patients should do. We should actually be looking at a set of principles. And so the authors of the textbook on principlism came up with four main principles that we should use, and they felt that these would be kind of applicable universally, and these were autonomy, so this idea of self-rule, that people are in charge of themselves and can make decisions on their, independently. Beneficence, the idea that we should strive to do good in our practice or in our ethical actions. Non-maleficence, which is sort of a related concept, but it's this idea of doing no harm, okay? And this is actually something that people get stuck on sometimes. It's not that you should not harm, but it's that you shouldn't harm disproportionately in the pursuit of good, right? So they're kind of different sides of the same coin, but you need them both to be happening at the same time. And finally, this concept of justice, which is really about fairness, about equity in distributing resources, but also like a procedural justice as well in how we go about making decisions. And so I feel like principlism does a lot of work and it's a good framework, but it's also not the best framework. But the reason that I'm sharing it with you today is because it's a framework that is known to a lot of people. And I think when you talk about an ethical problem and you say, well, I really feel like there's a tension here between autonomy and non-maleficence, it kind of gives you a common language that all clinicians have learned. So it gives us a little bit of a shorthand to start talking about ethical dilemmas. There's also a lot of things that principlism doesn't look at, right? It doesn't acknowledge power inequities. It doesn't actually apply to every situation. And so beyond principlism, I wanted to share your attention, point to approaches that are used in nursing ethics that I think are really interesting, really avant-garde in a lot of ways, and I think they really speak to the realities of our nursing practice. So the first is relational approaches, and relational ethics is a branch that actually came out of nursing, and it differs from principlism in that it really situates ethical action in the therapeutic relationship. And so it really kind of concretizes where we are acting ethically, and that it really gives us the impression that, or it asks us to consider in all of our encounters with our patients, to consider ethics or to consider this concept of the good in all of our interactions. feminist ethics. We talked. Natalie touched on feminism this morning. I think it's an ideology that is well suited to nursing. I think it speaks to a lot of the realities of nursing, but it also pushes us to think about power inequities and to identify vulnerability, which is really important in our patient populations, in the neuro population, when we're looking at advocating for patients with disability. I think this is a great framework that helps us also kind of interrogate structures of power, interrogate sources of vulnerability, and so on. And of course, with all of these approaches, there's a big concern for social justice as well. I want to point you to this textbook, which is written by Canadian nurse ethicists. So we're looking at Canadian legislation and nursing ethics. It's a fantastic textbook, and it's available for free online. And so they made this decision last year to have this book available for free. So we've got the URL, but, and this is my very first attempt at doing this, at making a QR code. So I hope it works. But this will give you access to that. It's a fantastic book that gives you some great analysis on ethical issues specific to nursing practice. Okay. It's not working? No, I'm so sorry. Okay.
It's fairly easy to find.
Yeah, so it's out of the University of Victoria. And so, yeah, if you look up the title, you'll find it also. And so I'll keep working on QR code making. All right. I want to talk a little bit about moral distress, because I think this is something that we encounter often when we encounter ethical dilemmas, and it's something that's actually very particular to the nursing experience. And I think it's also a feeling that we'll see in nursing practice, because we are working in these situations where we have very high responsibility in our work and also very low authority. And so holding on to those two pieces could be very distressing. A lot of nurses talk about moral distress as something that they encounter in their practice. And I think it's tightly related to ethics. And so there's been a lot of different definitions of moral distress. And so I want to talk about it, but I also want to problematize it as well. I don't think it's an unproblematic concept. And so kind of the OG definition of moral distress was written by Jameson, and they had seen this particularly in nurses working in acute and critical care, but I think it's something that is universally a nursing experience. And it's the negative feelings that arise when one knows the correct response to a situation, but cannot act accordingly because of institutional and hierarchical constraints. And we know also from the literature that moral distress could impact nurses' well-being. It could impact patient care. It could impact the healthcare system, because it is kind of a direct path to burnout, and it is an important threat to retention. And so we do need to pay attention to moral distress. But I don't love this definition. The first issue that I have with it is that, in the definition, it says where you know the right response and you can't act on it. And my first concern is, well, how do you know the right response? How do you know the right thing to do and nobody else knows the right thing to do? And so I don't want us to assume that we know. And so that's part of the kind of ethical deliberation. The second piece that bothers me, and this is probably what bothers me the most, is that moral distress as a definition and moral distress as a concept, I feel paints nurses as victims, and I don't see nurses as victims. I was at a conference on nursing ethics a couple of years ago in the US, and they were talking about moral distress and the cure for moral distress. And this was the keynote speaker of this conference, who said, what we really need is a glass of wine and a bubble bath. And exactly, there's nothing wrong with both of those things. But the problem with moral distress is not that nurses are weak or emotional, right? And so although moral distress could give rise to moral injury, which is also fantastic literature and a great concept to think about, nurses are not without power, without agency, and we're not, like, I hate the insinuation that the problem is me because I'm feeling moral distress in my practice. Okay, the problem is not me, the problem is not you. It was never, like, our distress is not the problem. And so I want us to kind of shift, I want to suggest this shift to this idea of moral agency, because it's a much more kind of accurate, I think, terminology to think about how we approach ethical issues in our practice. And so agency is our capacity to engage in deliberate actions. And I think that when we shift from distress to agency, we go from being kind of passive to being active in engaging with ethical issues. And I think it like, I would say that when you're practicing in any healthcare system, but I mean, especially with the realities of today's healthcare system, if you don't feel moral distress, I think there's something very wrong, because we are practicing in situations that are understaffed with highly vulnerable patients who are being sent home without the proper supports, who don't maybe have family support, who are not equipped to take care of their needs at home. And so if you don't ever feel distressed by what's happening, I think there's something wrong. But when you do feel distress, I feel like you're actively engaging with what's happening. You're actually plugged into the difficulties, the structural challenges that you're seeing in the healthcare system. So for me, distress is not a sign of weakness. It's actually a sign that your eyes are open and you're seeing what's going on around you. And so I want us to think about not, I mean, the distress is there, but I want us to really think about it as a structural problem. The problem was never the nurse. The problem is the context in which we are practicing. Okay. Oop, I went too fast. Oh, what happened to our idea for, oh, okay.
It's after.
Okay.
Okay. And so we're going to talk a little bit about neuropalliative care and why do we think that in neuropalliative care sometimes we encounter ethical dilemmas. What's different about neuropalliative care from conventional palliative care? Well, the first thing is that conventional palliative care was designed for patients who have cancer, and they're very different from our patients with neurologic disease. And so the conventional model is not always a good fit for our patients. Because our patients sometimes will be sick, very sick for a very long time, and not just in an acute fashion, but more in a chronic fashion, but will still need all those supports that are generally associated with palliative care. Our patients sometimes it's a little bit more difficult to recognize that they're dying or at the end of life because of their overall state. And so there's this prognostic uncertainty that comes from clinicians, but also from sometimes people who are on the receiving end. For example, in my practice, when I have to find a place for a patient to go, it's not always easy to have them accepted into a palliative care residence, because on the other end, they see the file and they're like, that person's not dying. The person's roles in life often will be affected in a greater way than in another illness, because of how their overall functioning is impacted, and they cannot necessarily fulfill the roles that they had prior to their illness. And their whole personhood is threatened. And I think maybe, Marianne, you want to talk about personhood a little bit if we have time, but the idea, and correct me if I'm wrong, but just because I heard you talk about it. But patients with, for example, a patient who has cancer will feel like the cancer is outside of their body and it's not part of them. But when they have a neurologic illness, they feel like their entire identity is challenged by this illness and it's becoming part of them. Okay. And so what are the impacts of this? Well, there can be gaps in care. There can be barriers, like I said, to receiving palliative care. And also patients, families are often more at risk of caregiver burnout because patients themselves need a lot more help. And that's 24/7 help. And so the resources for the families are not always there either. But my question is, can we still achieve a good death in this context? And this is where I want to have your input. What does the good death look like for you? Sorry? Yeah. That's, yes, painless. Thank you. Mhm. Comfortable? Peaceful? So two people here said dignity. Very good. What does that mean? What's dignity? Power over their own decisions. Yes. Thank you. It's a good one. What else? Yes. What the patient wants.
Good death is what the patient wants it to be, not being looked at differently. Someone else said dignified, painless, devoid of existential dread, surrounded by loved ones.
Devoid of existential dread. I like that. It's very specific.
Yeah.
Well said.
You've heard of the golden rule? I like, there's actually your comment was really helpful for that. The golden rule is treat others the way that you want to be treated. And now the palliative care narratives are is moving towards this idea of the platinum rule, which is how that you treat others the way they want to be treated. And so we're getting out of what we think someone should do or what we think someone needs, and really figuring out what it is that is important to them and going with that plan. And I feel like that resonates with a lot of the comments that were made.
Absolutely. And I think hence the importance of recognizing sort of our own, where we come from, what are our own biases, because sometimes what I feel like is a good death is not necessarily what my patient wants. And this is just a little parenthèse here, but I think this is especially important when you're caring for someone who, for whatever reason, you feel like it resonates with you, what's happening. Like, I know I have a tough time when I see like one of the spouses, the parent is sick and there's like 3 daughters in the room, because in my family we're 3 daughters. So I'm like, you've got to be careful here, you know. You don't want to project your own sort of reality onto theirs. And where was I going with this? Yes, so our perception of a good death is not necessarily what it is for them. So we have here a few points. So relief of pain, you said that, being close to a loved one, that also came up. Having the support of family and friends, feeling free to talk openly about death and about care. So that might not be true, for all cultures. So we have to be careful about that. Reflecting on life and having those reflections valued by others. The concept of reminiscing also. Trusting relationships with professional caregivers, super important. And finding meaning in one's life and death. There's a little quote too that I wanted to share with you that I found extremely comforting in my work with the dying. I often find myself in the face of people who are dying in different circumstances, and this quote in particular felt really comforting. It was, I hope that dying is like falling asleep as a child in a family gathering. when you feel yourself drifting off and you can still hear the laughter in the other room. I thought that was beautiful. And I can almost still feel it. Like Marianne and I were talking about it just before, and I used to fall asleep in like the piles of coats. You know, and you have everybody's smell and you can hear them and you're kind of drifting away. And I was like, wow, I really hope it's like that. And that sums up, you know, being comfortable, being well surrounded, having family around you. Okay. And so why in our practice do we encounter so many ethical dilemmas at the end of life? So neuropalliative care is a fertile ground because we have often very complex and very sick patients with many people around them because, like we said, there's a lot of caregivers involved. And so determining goals of care and wishes can be tricky at times, and it's not always the patient speaking for themselves. They can also have a substitute decision maker. They can have, most of our patients actually have communication difficulties. We have to always remember that because someone is aphasic or has trouble expressing themselves in a traditional way doesn't mean that they are incompetent or incapable of participating in goals of care discussions. And this is something that we are all guilty of because we're so busy and we're so pressed for time, but often we will defer to a family member very quickly because it's faster. So I urge you to sort of recognize that in your own behaviors. I do it as well. And it's like, nope, okay, try to shift my focus back to this person. So recognizing what's the patient's wish, what's the family's wishes, approaching nutrition and hydration. We often have patients who have a lot of technology in their involved in the management of their illness because they were ill for a very long time, and so they can have pegs, they can have trachs, but this kind of brings different questions when we get to the end of life. Comfort versus life extending care, what does that mean? And then supporting patients and families through grief. And grief sometimes happens before the person dies, especially with patients who have neurologic illness. It happens in themselves. It also happens in their loved ones who don't recognize their loved one anymore. Okay. So we're going to present you this framework, and then we're going to jump into the cases, and hopefully you'll be able to use this in them. So I think I have one thing I want to say before we even jump into the framework is, first of all, before we say, oh, we have an ethical dilemma here, I usually say, is this an ethical dilemma or is it just a communication issue? First of all, because I think we're very quick in judging and saying, oh, this is unethical, but wait a minute, what does that mean? And really, is this what we're faced with? Because it's kind of easy to then defer to someone else, you know? Okay. So for the framework, it's 4 steps. We start by identifying the facts. So name the problem. What is the problem? What's the question we have here? Then we determine the relevant ethical principles. Am I going too fast? No, because we want to. So determine the relevant ethical principles, and the big boss is here. Hi. Explore the options. So think about harms and benefits, strengths and limitations, what laws are applicable, and then act accordingly. And so does that make sense? Maybe I should give a little more detail, or do we want to give more detail in each step? Yeah, go ahead.
So, I mean, I think you.
Well, I was very brief.
Went over. So the only thing I would add to this is, like, we wanted to give you sort of a tool that you could take with you in your practice. And this is a commonly used framework that's I think it was actually developed in nursing. It uses the framework of principlism. So it gives us that common language, and it also gives us kind of a cycle to go through. And what you'll see here, and so it is based on principlism, and it's also based on another framework that's called accountability for reasonableness. You'll sometimes see it referred to as A for R, number 4, R, framework. I think it's a fantastic framework that actually describes conditions for a fair decision-making process. And I think that's really key. And so there's 4 steps to the idea framework and then 5 conditions. And anyway, you take a photo of this or you could look it up. It's really easy to find, and it gives us just some support for making decisions. And I want to point out 2 things. The first is that some of the hardest work you'll see, actually, okay, 3 things. You see that it's actually cyclical. And quite often in ethics consults, we're actually going to go through this cycle multiple times. And sometimes there's like, and quite often, actually, when ethics gets called for a consultation, this issue has been going on for weeks. There's been some overt outward conflict. No one is speaking to each other. Sometimes the police or security has been called because there's been some fistfights. I mean, tensions are really high. And there's a lot of very complex issues that are going on. And so when ethics gets called in to intervene in these types of dilemmas, it takes a long time to kind of tease apart everything that's going on. Like Justine said, there's some communication issues, there's some relational issues, and then what is the actual issue at the core of this problem? And sometimes there could be 3 or 4. And what we'll sometimes do is we'll resolve one of the 4. And then we need a little bit more information. We need a little bit of time. We need, the temperature to come down. And so sometimes it feels like we're not progressing very quickly, but we're actually going through this cycle multiple times. And it didn't take a day for like the patient family healthcare team to get to this particular situation. It's not going to take us an hour to get us out, right? And so it's going to take some time. And so sometimes we'll kind of come up with one solution. We'll try it out for a few days. We'll see how things go. Maybe there'll be a clinical evolution, and then we'll have a little bit more information to be able to act. So the first part is that this is going to happen multiple times. The second piece that I wanted to point out is that we spend most of our time in this framework in deliberation. We're kind of collecting information and we're deliberating. And I want, when you're working through ethical dilemmas, I would want to encourage you to stay in the messy middle. Lean into your discomfort, stay with those uncomfortable feelings, and don't rush to intervention. Okay? We're very good at intervening as nurses. We want to do stuff, we want to help. We've got tools, we've got meds, we've got all sorts of things that we can do to help. And this is kind of counterintuitive. So stay with the discomfort, stay with that icky feeling, and spend a little bit more time in deliberation. The third piece is that the hardest part in an ethical dilemma is naming the problem, and coming up with an ethical question. And once you could name the question, once you could name the dilemma, the values, the principles that are at stake, you've actually done 50% of the work. And so stay with that and don't rush, and spend a lot of time talking to people and gathering information and tracing implications on a large number of stakeholders for their present, for their future. What is important to you? What is a good life for you? What is a good death for you? All of those questions are things that we ask. And for me, at least, when I hear an ethical issue and I feel like, oh yeah, I'll be done, lunch in an hour, this is going to be easy, that's when I'm 100% wrong 100% of the time. So just when you start feeling comfortable, like question that as well, and keep just push. And I think that deliberation will actually get you a lot further.
Yeah, I think that's really good advice.
So,
and I think this is also, it resonates in terms of the practice in palliative care. I would say that often it's where we're really uncomfortable as clinicians that will make the most progress with our patients and our therapeutic relationship. I find that when I feel like I need to get out of the room, when I feel like, oh my God, it's time to run now, that's when actually, no, it's really important that I stay. And this is sort of when the magic happens, although there's there's no such thing, but anyway, okay. So any questions so far? Well, for the cases, we're gonna jump in now in the cases, so maybe we can sort of run around with the mic. Yeah. Well, I think for people online, it's gonna be easier, right, to hear?
Oh, they need the mic, yeah.
Yeah.
If we do question period now, we have.
All right. It's time for karaoke.
I know.
Okay, so we'll start with Mr. B. And oh, des questions avant? No, no, cases first, and then questions. But they'll have to participate. That's why, yeah. All right. Is that okay? Everyone's, are we all confused? We're confused. Okay, that's cool.
We want to also point out that these cases are drawn from
Thank
clinical
you.
practice, from Justine's practice, and maybe one
And
more
yours.
from my practice. And so, and some of these cases might be familiar to those of you who work here. So we'll just, if you recognize the patient or if you recognize the situation, we'll just hold on to le secret professionnel.
Mhm.
Yeah, Vegas rules.
I think they're fairly well anonymized in terms of we changed critical details. But the idea was also to make it relevant to your practice. Okay, but thank you for saying that. So Mr. B, a 67-year-old man with ALS, he was admitted to the hospital with aspiration pneumonia. Sorry, I missed a word there. And general deterioration. He's level of intervention C, comfort and quality of life over life extension, treat easily reversible conditions, no CPR, no ICU. He's becoming delirious and he has pushed staff away while they were trying to put his BiPAP on. He's increasingly difficult to understand due to speech impairment. The RT insists that he needs to keep the BiPAP on to keep his saturation over 92%. He now has a pressure ulcer stage 2 on his nose from the BiPAP mask. The family is distressed. They don't know how he would want to proceed at this point. Any ideas? What do we do?
Raise your hand.
What's the problem here? Is there a problem?
Or shall. Raise your hand or shall.
Start by trying to find why is he delirious? Like, look at the risk factors.
Good question.
Mhm.
Why is he delirious?
I'll read the comments
Yep.
there so that you
Okay,
can
sure.
just go around.
I think Heather had a question too, or had a comment.
All right.
Again, it's just another question that I would want to know. I would want to know how he was with his BiPAP before he became delirious and whether or not he, seemed to appreciate the BiPAP prior.
Thank you.
Thank you.
Some comments in the chat. Autonomy impaired, but may not be as competent as he is delirious. We might want to include family members, advanced directives, etc. Stage 2 pressure ulcer increases the harm.
I'm wondering if we need to keep the SAT over 92%. I was just looking at our protocol and advanced ALS, probably CO2 retainer. Are we good with 88? So
It's an excellent question.
what do we need?
What do we need here?
Another comment in the chat, this might be difficult as he might be delirious due to CO2 going up and need the BiPAP to decrease that.
Any other comments? Any kind of questions that you have? Like, what is it that you know and you don't know? We've heard some kind of principles that are in tension. Any other thoughts about this case?
What is the family distressed about?
Someone mentioned maybe an intermediary measure to improve quality of life could be high flow nasal cannula to mitigate the nose pressure injury risk.
No. Sorry, that one I have to say no. And we have an ALS specialist in the room here that's very dangerous to give oxygen to patients with ALS. So if I can put it out there in most contexts. Thank you for trying, whoever that was. The idea was good. It's just in other illnesses, it would have worked.
They said good to know.
Peut-être à ce moment-ci de la situation, c'est de s'asseoir avec la famille, les médecins, l'équipe multidisciplinaire, puis justement leur évoquer les différentes to say different options. There may be an option here that maybe is more invasive or more like to help him relax, but he may desaturate a bit more, or there's different options. Which one of them he would be comfortable with and you would be comfortable with at this point, you know?
So to clarify with the family what they understand of the situation, also.
What are they ready to do to help?
Yeah, thank you.
Yeah, you can't speak in French because we have no idea what the AI will write if you do that.
I think
You can
before
still speak
all
French.
that,
We'll
we-
just let the robot do whatever it wants to
Okay.
do. It's okay.
okay, is delirious, so we need to treat that first. Is he on antibiotic? He is, because you said he has pneumonia. I guess he's on antibiotic already. Does he have a urinary infection? I don't know. We have to.
So there's more information you would want to know.
Exactly.
Yeah.
Exactly.
Good, very good.
I don't know if somebody already mentioned this, but I think there's something to be said about the comfort and quality of life over extension and what that would mean for this specific patient.
Thank you.
Mhm.
Yeah.
Thank you.
We can also take into consideration how much he's deteriorating and if there's like a significant change in status that we have to reevaluate the level of care. If it's just a delirium and it's reversible, then after treating that, but if it's not just delirium and it's just progression,
Of the illness.
yeah.
Mhm.
Okay.
Thank you.
Is the RT suffering moral injury?
Well, I mean, that's a good question, right? Who is suffering here? That's something that I often ask myself when we're in the face of situations like this. Who's suffering here? You know, and probably the RT is distressed, and I don't blame him or her.
Mhm.
Pushing away the staff away. So could it be that he didn't want anything at first, but how was he before the defibrillator? Was it something that he was accepting before?
So,
Yes.
yeah.
So Sati was saying, what does it mean if the patient is pushing the mask away? Is that something that he didn't want? So I
Mhm.
think from before, yes. Yeah. Yes, that's a good point. Thank you. Chinit?
Actually, can I
I'm
just-
curious to.
Oh, go ahead. Yeah.
Sorry, I was just curious to know, like, the discussion about the level C,
Yeah.
was that discussed with the family or the patient? And what do they understand in terms of the level C? Like, because sometimes we say level C, but they don't know all the circumstances and when they deteriorate level C, what does it mean? So
Mhm.
it's something maybe to.
Thank you.
Thank you.
I think you both brought up two really important pieces here. And one of the reasons we like this case is because there's already been a level of care discussion, right? We've got a level C, but we see also that even in that decision, there's a lot of gray about how to go forward, right? So it doesn't actually give you 100% a path on how to go. There's still some gray issues to work out. And the other comment that I want to speak to is just because the patient is now suffering from delirium and they might lack decisional capacity, right? Lack of capacity doesn't take away your right to express a view. And that's really important, right? So we can't just cast aside. I think there's something being communicated here that we need to pay attention to. And we have to give that a lot of moral weight.
Yeah, absolutely. And we have a case too about category. Oh, yeah. je pense que-
Yeah, so we'll look at that again later.
Yes, but that's very important. So anybody wants to add something else? I can tell you how this case, what the resolution was. So maybe this was a team problem because our approach was not universal. And so, you know, I don't think everybody on the team understood level of care C the same way, like you guys brought up, like Chinit brought up. And in this case is so it was very clear for the patient that he wouldn't want his life prolonged with a poor quality of life. And I think there was a little bit of this poor recognition of the dying at this point. Like, was he dying? Was this advanced ALS with an infection? Like, what were we supposed to understand from this situation? And indeed he was at the end of his illness. And so what we did, he did receive antibiotics for symptom management, but what was decided was to give him palliative sedation and to remove the BiPAP, and he passed away peacefully quite rapidly after that. Any questions? No? Okay. So we have Mrs. F, who's 76. She has end-stage glioblastoma. She's admitted for general deterioration and difficulty coping at home. She's awake for short periods, able to communicate with yes and no. She's refusing to eat or drink at this point. At admission, an NS was started at 60 cc's per hour IV, and now her IV is infiltrated. What do we do? Is there a level of care? Yes, there is. There's level C. Again, that doesn't solve our problem, right? It doesn't give us a conduct.
C for clear.
C for clear, yes. I love level C. Thank you. Yes. Well, this is what I was hoping to hear. She can communicate with yes and no. So when she's awake for short periods, so we can ask her what she wants, right? Very important. I think this is something that could have been easily missed because of the fact that she was asleep most of the time. Yes, more from online.
The dilemma is whether she needs ongoing IV fluid or a new PIV. Is it whether she needs nutritional support? Question mark.
That's a good identification of the problem. Thank you.
Okay, those are great. So how would you, if you're using the principles, like what principles do you see as being in tension? Maybe I'll go back to the idea framework.
I haven't gotten my answer to that yet, but my question behind this idea of the PIV is like, what's further than that? It's not, the question is not just about a PIV. No one would be in like ethical dilemmas about a PIV unless there's something else going on. And it's like, are we in end of life? Is this something where the patient wouldn't want this type of care? So being able to articulate what's going on more than that will help us answer the nitty-gritty question of, do we put in an IV or not?
Beneficence, autonomy.
Yeah, no, that's what I was going to say. I was going to say I will go with beneficence, like in terms of like benefiting the patient by meeting their nutritional requirements versus non-maleficence of not respecting their, I guess, autonomy, but their wishes to not eat.
Yes.
Thank you.
And like the pain of the needle.
The pain of
There's always the pain of the needle. Yeah. I mean, in the scope of doing harm in the hospital, I think it's fairly low, but it's still something we need to think about because in patients with cancer, often their veins are terrible, right? So what seems like a benign intervention can actually be really, really hard to do.
Someone in the chat mentions, if you look at the idea framework, I don't think there is an ethical dilemma here yet because we can ask her what she wants.
That's a very good answer. Yeah, exactly. And does anybody have someone else to add? I can give you the resolution. So in this case, yes, it was that's what we did. We talked to her when she was awake, and we sort of knew which times of the day she was more with it. And it was good because this patient was known for a long time by the physician, and there was a trusting relationship that existed. So that helps a lot too. And that helped her husband make that decision of not putting the IV back, because it absolved him of that weight of the decision. And I don't know if this is something you actually encounter a lot in your practice, but I find that family members feel so guilty, and that burden of decision is really awful to bear for them. So when someone has expressed their wishes previously, or if there's a level of care that really sort of takes it away from them, and this is something that I often talk about with families and say, look, this is not a decision. This is not your decision. This is something that we're doing because your wife said that's what she wanted, and she's making that decision. We're just respecting it. And I think as a team, it's really important that we have that approach, so that family members, they're the ones who will survive this, and we don't want to cause any sort of complicated grief, because think about it, it's really hard. Now this lady died, but it took like 2 weeks, She was at the end stage of her illness. It was recurrent glioblastoma. She was no longer able to feed herself or hydrate, but without the IV and without any enteral feeds, she still managed to survive 2 weeks. And so we had to do a lot of sort of reinforcement with the family that, no, this is okay, and this is the natural course of the illness, and we're making sure she's comfortable. But it's quite hard to avoid that sort of guilt feeling of seeing someone die without food.
What is the clinical utility of IV fluids at the end of life? What are we doing, and what are the risks?
So here, go ahead. Yeah.
From my school education, that is a bit old, but I remember that being dehydrated was actually more beneficial for the patient than hydrating them or having a maintenance fluid at end-of-life care.
Mm-hmm. Well, maybe we can talk about that a little bit. Like, why do we think it would be beneficial? It's actually quite logical. Yeah, makes you a little bit delirious, not too cognizant of what's happening.
Someone mentions can exacerbate terminal secretions or third spacing.
There you go. Yeah. So that too, and we see it clinically when someone is taking IV fluids, it goes to their lungs, and it's really quite hard to manage their secretions at that point. So there are reasons why in those textbooks it said that it was beneficial. And I tend to agree with that, but I can't say that that's a one size fits all approach. Yes, someone wants to say something? You went like this. No.
Finish your.
Well, just because in some cases, when it's too difficult for patients or families to let go of that, you can sort of come to a middle ground where you give some IV fluid and monitor closely for signs of third spacing, increased secretions. Mm-hmm. There is, you could give subcutaneous hydration at a very low rate. We don't do it so much here. They do that more on PCUs. It's a little bit difficult on the sites sometimes. So if we still have an IV, I think it's easier. But with more risk of third spacing and having fluid on the lungs. So it's more of you have to be very closely monitoring all those signs, because then if we get into that loop of like you're hydrating, but you have to give Lasix, it's like, what are we doing here really? Mm-hmm. Any other comments or questions?
I think like ultimately it's the meaning of the hydration, the meaning of the food, the meaning of no longer doing this for this person, and like, the psychological and
absolutely. And I think in nursing school back in the day, also we were taught that it was only a certain cultures had a lot of difficulty with stopping feeding. That's a lie. That's everybody. It's not just certain cultures. Like seriously, everybody has trouble doing that. And so it's just human nature. But I think it's important to remind ourselves that humans have been dying for millennia without having NG tubes in their nose, right? Our bodies know what to do when it's time to go. And obviously we have to be very clear and mindful and sensitive when we explain that to families. But I think generally people respond well to that. Like our bodies know what to do. It's still true despite all the technology that we have.
Yeah.
Anything else?
Well, and refusing to eat or drink is a sign of the terminal stages, right?
Yes,
And so
absolutely.
we've got it. I think, like to your point, we need to pay attention to that. And if the patient is refusing, it's also like an indicator.
It's a sign, yeah. And most patients are not hungry. It's not even an issue. It's really us projecting our own hunger on them. But patients who have been in bed for a really long time are not using any kind of calories. They're not hungry. Think about how you're feeling when you have like COVID, you know, you're not hungry. You just want to be in bed and not be bothered. And so it's the same thing, really. We're our own worst enemy when it comes to things like this.
All right. We'll move on.
Another one? Yes, Angela? I can repeat.
Family. So often family isn't just they're grieving and they don't know how to live it. So feeding someone is an activity that they've been engaged in, and often in many families, whatever.
It's how they show.
That feeding someone is a very important act of
Yes.
loving. So it's often like, how do you fill that gap now that it's gone?
Yeah. So for the people online, Angela was saying it's a part of the care we offer for families is for them, it's important to continue feeding the patient because that's how they express their love. That's how they were caring for them in the past. And how do you now move on to another way of caring for your loved one? Did I get it? Yeah. Okay. Thank you. Yes, absolutely. Yeah.
I would ask, okay, so we've gone through the principles. Like, what would a feminist analysis of this situation look like?
Really?
Why is that funny?
Why is that funny?
Right. What would feminism say? What would a feminist analysis say? I think we would look for well, first of all, the feminist model, like it's kind of like math, you know, you want the formula to fit the problem, you know, you want to pick the right formula for the right problem. I obviously don't do a lot of math, but like the feminist framework is there to help you think through the ethical dilemma. Is there a context of vulnerability that is unacknowledged? Is there a power dynamic that needs to be explored, exposed, uncovered, addressed here? Not maybe there is, maybe there isn't. And so here, for example, you know, are we overriding a patient's wishes because they're not able to have a meaningful conversation, you know? And so that is one way that maybe we would use a feminist framework to think through this problem. Are we ignoring the patient or excluding them from participating in their care because we have an assumption that a lack of verbal speech means a lack of capacity? Well, I would interrogate that, for example. So that might be a feminist approach. I don't know that that's like the right or the most pressing problem here, but it's certainly how you would look at this through a feminist lens.
Thank you, Marianne, actually. That's very
Someone in the
enlightening.
chat said, what about social justice, medical paternalism, perhaps?
In what sense, I want to ask, though, that we're deciding for her, or
We'll see.
if the person wants to elaborate, we're curious.
Yeah.
How can we be culturally sensitive?
That's another very
much
good
time do you
question.
have?
Yeah, how much we can stay on that.
And I think the next case actually talks a little bit more about those types of dynamics.
Yes.
Yeah. So maybe we can go on. Having considered the implications of cultural or SES implications, absolutely. Those are very, very important to think about. Thank you for bringing that up.
Thank you for bringing that up. Yeah.
And those are things that we always need to kind of keep in mind.
In this case,
Yeah.
the patient was a white female French Canadian, and her husband as well. That's it. I don't have nothing else.
And I think it's a
it's-
case by case to
But I
look
think to the
at-
point of
yeah.
also what I was saying before is like, we often associate those problems with cultures from like Europe and Italians. That's what I was taught in school. I can't believe this, but yeah, it was like, it's only Italians. It's not true. It's everybody. And to that point, this person was French Canadian. I don't think they teach that anymore anyway. I hope. Seriously.
Yeah. I would love to kind of put a pin in cultural competence because it's a huge, huge topic. If we have time at the end, we'll talk about it, but I think we could spend like an hour and a half just talking about it. I struggle a lot with this idea of cultural competence. I don't actually think we can ever be competent, and I
No,
don't think that
exactly.
it's something we should strive for. I struggle a lot with that terminology. And so I don't want to sort of like sidestep the question, but I think anyway, if we have time, maybe we'll address it in the end. And actually to the comment that was made online, I think a social justice framework might be more inclusive than thinking about cultural competence, maybe.
And I think I prefer the concept of cultural humility rather than, or sensitivity even, or safety. Yeah, but I think actually what I was taught was more like cultural competence. And I remember they were trying to show us like, oh, this culture, it's that, and this culture is like, I don't think that was helpful in any way. If not, it just reinforces stereotypes. And so I don't think it's necessarily the right approach.
All right.
Okay, moving on.
So the cases are getting more difficult as we go along. So these two were just like a warm up, and now we're going to get into the weeds with you with like the hardest ones at the end. But now that you're like becoming experts, we're also asking more of you. Okay. Okay.
Do you want to read this one?
Sure. So consider the case of Mr. Y. He's a 75-year-old with multiple comorbidities due to aging and having had a good long life, with a newly diagnosed brain lesion. He tells you, his nurse, that his quality of life is not great, and he says, "I'm ready to die." Not a long time later, speaks to the surgeon and agrees to a surgery to remove the lesion. So he goes ahead for this surgery, and post-op, he develops pneumonia and he develops a surgical site infection. And the family decides that they want to go on with curative treatment for his infections. The patient is in a lot of pain. He's refusing care. When you try to approach him to provide care, he pushes you away. What is it that how do you kind of see this as a dilemma? Where do you go? What do you do? What are you thinking?
Did he change his mind about interventions? Is there a knowledge deficiency to address? What has the discussion been like? Surgical resection seems pretty invasive. ...
All right, that's a great start.
Depends who you ask. That was good.
Ask the patient what he wants, another comment.
Yeah. What about level of care? Is there one? Yeah. There is none.
Yeah.
Yasmin?
What did the nurse do when he said, "I'm ready to die"?
What did the nurse do when he said, "I'm ready to die"? Yeah, so did we explore what that meant? Also, did she share it with the team? Yes, Dorothy.
But if that is no longer an issue, quickly think it out and become, but in the moment, and you you know, with antibiotics, get over it, you know, does he understand that? Like, he makes the proper decision. Like, kind of remove something that he change his mind. I mean, to go in that direction. Because maybe has changed his mind. He accepted surgery. So he had a certain different outlook, different view, and hope to get out of it. So,
So what Dorothy was saying for the people online is to explore the understanding of the patient and what is it and how it has evolved. So what did he understand of the brain lesion? What does he understand of the pneumonia and how it's going to affect his life? And if he did change his mind over the course of his hospitalization for the brain lesion, then maybe he's changing his mind again. So to explore really his understanding of what's happening and the treatments proposed. Thank you.
A comment in the chat is pneumonia and surgical site infection are common complications. Did we explore the risks of the surgery beforehand? And then why is the family deciding? Is he no longer competent?
Great questions.
Very great question.
Yeah. So everything was, I mean, there was informed consent prior to the surgery. Yeah.
There was informed consent, and the family is not fully sort of substitute decision-making in that stage yet, because the patient is still awake and alert.
I'm just wondering, like, even if there was like consent and all, did his family influence him to do the surgery? Because he said himself, I'm ready to die. He knows he has a bunch of comorbidities, but then did someone talk to him? Did he talk to his family? And that made him, you know, change his mind.
So. Good question.
Thank you.
Thank you.
I was wondering, did we rule out delirium? If he has pain right now, if he's got an infection, maybe like could be worth treating the infection on a palliative basis.
All right.
Was he coerced by MD or family?
Coerced.
Feminist
I think
analysis.
that's a great question. And I think coercion is a
it's a strong word.
It's a strong word, but it is definitely, there's like a continuum, right? And I think, yeah, oh, it was from the cat. So it's a great question. And I think so I just want to kind of like add some nuance to this idea of coercion, because we'll often use that word. Usually what we'll see in healthcare, because there's a continuum, right, of different amounts of pressure that we might put on people to have them kind of take on a certain point of view that we want. Coercion is to say, if you don't accept this surgery, I'm going to go burn your house down. That's coercion, right? You're using a credible threat of harm to induce someone to do something. And often what we don't actually see things like that. I have seen that actually in the hospital. There was an ethics consult about this. But in a different, anyway, sometimes we do use coercive
Stop
measures.
everything, what?
There's a patient an elderly patient in a chronic bed. And he had he's just existentially, I think, suffering. And some days quite old, like not acutely ill, not actively dying, but just, like in that place, right? And the nurses would come and give him his morning meds. And sometimes he would say yes, and other days is like, oh, I don't want to. And the nurses had come up with a strategy with the wife where if the wife was not there, they would say, what? You're not taking your meds. You're not supposed to do that. I'm going to call your wife and tell her. I'm going to call her right now, pull out the phone and start dialing. And he would say, okay, I'll take it. Okay. I don't know what credible threat was being I don't know what she was going to do, but a nurse called ethics and said, this is what's going on, and I don't feel good about this. Is this a dilemma? And I was like, I'm coming. So anyway, that was coercive, right? We don't know what it would. I don't actually know what the credible threat was, but he was clearly afraid of whatever his wife was going to do when she knew. And then I'm like, why are you forcing meds on him? What is like, why is he saying no? Could we wait a minute? Does he need something? Does he want to wait? Does it have to be at 7 a.m.? You know, like there's all of these other questions, but I think that was, anyway, sorry, parenthèse, that's coercion. But what I think we see more often in healthcare is persuasion, manipulation, some sort of like leveraging of an interpersonal relationship. You know, maybe selectively offering information. I think that's what we'll see more often than not. But I think that there is a question about what was presented and how did this patient come to this decision, because we have one statement, which is, you know, I'm ready to die, and another that says I'm accepting a neurosurgery. So,
but at the same time, I think it's important to remember that patients will not say the same things to everybody on the team, right? Because they don't have the same, and it doesn't mean that one is true and the other one is false. These things can all be true at the same time. He can be ready to die, but he can also be like, okay, I'm giving this a shot, you know? So I think it's easy sometimes as nurses to sort of discredit everything else and be like, no, but he told me, but it's like, okay, but there's multiple people on the team too. And I think patients feel more confident being vulnerable with nurses. That's the thing, but it doesn't mean that that's their only truth.
mm-hmm.
I think we're running out of time.
Just two more comments, because I think they were interesting.
I was
the
just going to
patient-
say, the main thing here is he's in a lot of pain, so it's hard to even have a discussion with him if he's really clearly uncomfortable, as
Yes.
said in the text. So first things first, make him comfortable so we can
Yes,
actually
treat his pain.
rediscuss this and bring these issues up so we get a clear idea of where he's at this time in terms of his wishes.
Thank you. That's very true. Yeah.
So the other comments were, was the patient made aware of MAID, and was he assessed for competency to make this decision?
Not in this case, no.
And the other
It was
comment,
pre-made.
It's not something that you've offered to patients,
Yeah.
right?
also.
I think it's really important to not say like, did you know that you can ask for MAID? Like, you don't offer MAID to patients unless
And-
they're
and-
actually actively seeking out your input on what their options are for their end of life. Like you don't just offer MAID to patients.
Yeah, thank you for expliciting that. Generally, our approach in palliative care is not to withhold any information about MAID, and obviously it is part of the sort of, it's under the umbrella of end-of-life care, and it's part of the options, but no, that's not something that we would do d'emblée, especially if, like, there's a lot going on in this case right now, and I think it would be not to, I don't want to say bad things about that person's comment, but it just kind of feels icky a little bit. Like, you know, it's like, oh, all of this is going on, but maybe we need to talk about MAID. It's like, no, not yet, you know, and this is something that if it comes from the patient, that's one thing. But generally speaking, as clinicians, we don't offer MAID like that.
Mm-hmm.
I think it kind of goes back to what Yasmin was saying, like really understanding what the patient means by I'm ready to die.
Yeah.
Like exploring that further doesn't mean they're ready to have MAID.
And it doesn't mean that they're ready to die now, you know?
Yeah. I
Not
think it's
not necessarily.
it's really important to like, yeah.
It is a lifelong process.
I think we often are looking for certainty. And so when we hear something like a declarative statement like this, we want to hold on to that. And I just want us to like resist the binary, you know, like let's resist sort of all or nothing thinking. Like like Justine said, two things could be true at the same time. And we have to make room for that. We're not kind of two-dimensional people. We're complex. And so we could hold on to like multiple competing things. Oh yeah.
Yes.
Yeah.
I do have
Actually,
it.
and I wanted to add one other dimension in this case I think was really important, is that I think that even with a guarded prognosis, I think that dying of a complication could be really hard to accept. You know, and I think there's a whole bunch of unacknowledged grief, even when you have a terminal kind of prognosis. And I think there's a lot of work to be done there about acknowledging that grief, and it's almost like a compounding loss if this patient was to die of an infection.
Yeah, and I think it's part of our role too to talk about complications as being part of the illness, really, and to remind them that, for example, if someone has a PE and dies, well, it's because they had a glioblastoma that they had a PE, and it's part of dying of cancer is dying of those complications. But it's super hard to accept for sure because it feels like, oh, you're up against that disease, that beast, we're fighting, and then you get taken out by like a blood clot, but it's like that's actually part of it. In this case, so I just not to go into too many details, but because we don't have a lot of time, but in this particular case, it was quite of a long resolution, and it was a lot of sort of back and forth with the multi-D team and with the family. And in the end, the patient did die. It could have been better. So this was a tough case because I think the medications for comfort were brought in quite late in the trajectory, and there was still some attempts to get those infections under control, and that lasted for maybe a little too long. But then again, this was that person's trajectory and with the family that they had in the context of the illness they had. So in the end, they passed, and I think this is sort of the inevitability, of those situations is that I think sometimes we also have to sort of look at our own ego, and it's like the disease still won in the end, so anyway, so that was a tough one. I don't think we have time for
One more
the
case?
rest.
We have time for one more?
One more case? Oh,
Oh, yeah. What?
no, I think let's do one more case and then
Would you like that? Yeah. Ooh,
Yeah.
which one do we do though? Because we've got like some hard ones.
unless you guys are all cased up, but you're like, no. Okay.
Okay.
I would say either this one or
Or the last one. Okay, we'll give you the choice. We have a complex clinical case, and then we have a case of how nurses allocate their time to like kind of a resource allocation question when the resource is actually the nurse's time, and making decisions on prioritizing care. So who wants the medically complex case? Okay. Who is interested in the allocation? All right.
okay.
Okay. Allocation it is. Okay. Here we go.
All right. So this case is called I'm Too Busy. So you're a nurse on a busy medical ward assigned the following 4 patients. There's Susie, who's 86 years old. She's in delirium and she's yelling that she needs help. And she's at very high risk of falls. Then there's Jeremiah, who's 46. He's admitted for a lower GI bleed. He's dizzy and his blood pressure is low. A repeat CBC is ordered, stat. And then there's Mavis, who's 75 years old. She has metastatic pancreatic cancer. She's at the end of life, level D. Her family's at the bedside and the sedation is ordered PRN. And Elvira is 61. She has a stage 4 pressure sore. She requires IV antibiotics and has a VAC dressing that is due to be changed today. How do you prioritize your care and who do you see first? This is your caseload for the day.
Mm-hmm. So let's stay with the analysis instead of an answer. So
Yeah.
What is at stake and what are we, what is the crunchiness here in this dilemma? The age?
What about
The
the
justice.
age?
The 40s. I would think my initial thought was like age. I would consider age in some of the situations, but at the same time, like even if you're 86-year-old and you're crying for help, like why are you less valued than the 46-year-old?
Mm-hmm.
Are you in a safe area? Can you wait a couple of minutes? Can I delegate? but yeah, if it's something that has to be done in a day, like a dressing, I can do that later on. The other one, the end of life care, you can always quick buy, say, as soon as I'm available, I'll come and see you. But I think I would go for the 46-year-old CBC analyze, and then I'll go for the 86-year-old fall.
Okay.
So if I could paraphrase in ethical terms, I'm hearing you kind of looking at, do I prioritize the most vulnerable patient? Is age the criteria for vulnerability? Is medical acuity the criteria for vulnerability? And how am I kind of defining beneficence and who's at most risk if I don't see them first? Sort of a,
I would actually not agree. I would actually never put ages. I think there is too much ageism. I think a 97-year-old can be as healthy as a 46-year-old, but we focus on age. We should focus on everything else. So I think even in all of these case scenarios you're given today, the ages to me is irrelevant. It should be everything else. If the person is healthy and they're 97, you know, that's your focus. If the person is healthy, not healthy and they're 46, you know, your focus should be on the issues going on. I think we're too stuck in ageism sometimes. When I started nursing, when no hip replacement was ever done on an 80-year-old and over. So I think we have to be very careful with that. So in all of this, I don't know if their nurse can ever make the right decision. I think they have to make the best decision for them on that day and be confident they made the best decision. It may not be necessarily, there can be errors with that, but it's the best decision that they could make on that day.
Yeah, thank you. Can I just add to that a little bit? Because I think you brought up some important tensions. So what we're looking at is actually a question of allocating scarce resources. So it's sort of, you know, you have one organ and 5 people who need it, and how do you prioritize, you know, who gets it? And so there's certain criteria that you look and you base yourself on to make those kinds of decisions. The scarce resource that we're looking at now is the nurse's time and the priority, right? So it's like these micro decisions that we're having to make. So what is our criteria? And you know, you're problematizing this idea of ageism. And so what do we mean when we're looking at age as a criteria? And while it's true in resource allocation questions, so for example, during the pandemic, when we're looking at who we're going to allocate resources to, one criteria would be kind of life expectancy, right? So a 5-year-old, if you save the life of a 5-year-old, then they've got a long life ahead of them, ostensibly, theoretically, versus if you save the life of an 85-year-old, they have fewer years ahead. And so how are we using that as a criteria to make our decision? You know, and is that the only criteria? And so, absolutely. So it's a question of like, what is the rationale behind the criteria, behind the decision that you're making?
So someone in the chat said, consider immediacy and magnitude of risk. B can be imminently life-threatening. It's like an Eisenhower matrix. Delegate what is important but not urgent. Do what is important and urgent. Someone else said, life-threatening can be mitigated by treatment if done sooner. And one last comment in the chat, what can we delegate to other members of the team? Like, can we ask a PAB to check on Susie to mitigate fall risk?
It's a very good point.
Great.
Yeah, I was going to say the same thing. So I think for Susie, you can delegate it to somebody, and the first person would be that I would go see would be the 46-year-old gentleman, Jeremy.
Max?
I disagree. So there is only one known medical emergency on that page, delirium. So I don't know what a PAB is supposed to do about delirium. I think that patient is priority to manage the delirium.
You don't think a lower GI bleed is priority when the BP is low?
Well,
I mean, not priority. I mean, sorry.
it's not the CBC that's going
emergency.
to change the course. So, I mean, you know.
Okay.
So I think it's important to go through the the reflection of priority in these kinds of situations. But obviously, I'll put more of a management hat on and look at systemic resources as well, right?
Yeah.
So first thing I would question, is that a reasonable assignment first?
But I'm happy that you bring this up, but at the same time, I feel like the reality that we are faced with right now is that the hospital is so undercrunched that all of our patients are sick like this, right?
Absolutely.
Most of them.
However, by having that discussion with your peers and maybe your assistant nurse manager, maybe it becomes a group effort and it becomes group prioritization rather than one sole nurse on a unit being stuck trying to go through this process in her head, right? But I totally understand. I mean, we're faced with the kind of people that come through our doors, right?
Yeah.
And the resources that we have to address their needs. But and then I would see what's in the nursing team scope. We have nurses, we have LPNs, we have patient attendants. How best can we also partner up with families and significant others? Do they have people at the bedside that we can also rely on, that it's a pair of eyes? Anyway, that's all I wanted to add to the context.
Thank you. Yeah.
Thank you.
Thinking outside the box.
Opening it up. Okay.
C'est bon? Okay. All right. Well, thank you all for, what's the answer? I don't know. Thank you for being here. Thank you for participating so well. We can continue offline after on that one.
Yes. All right. Thanks. Thank you.
We're running just a few minutes late. I'm sorry to our next presenters.